Hello, I'm Professor Hugh Jones, consultant diabetes and endocrinology, and honorary professor of andrology at University of Sheffield in the UK. This poster presents early data from the worldwide audit on testosterone and diabetes, which is supported by the Association of British Clinical Diabetologists, ABCD, in the United Kingdom. So patients are recruited to the audit from clinical centres around the world, and the patient data is inputted either retrospectively or prospectively. Each of the centres' data is encrypted for looking at the whole audit, but each centre can audit their own work. So we know that testosterone deficiency is very common in type 2 diabetes with a prevalence of 40%. This is largely not treated by many people, but there's increasing evidence there is value in giving patients treatment. In the audit, patients with on testosterone therapy can be included, as well as those who are testosterone deficient who are not treated. Certainly, we know that testosterone deficiency is associated with poor quality of life, sexual dysfunction, increased cardiovascular risk, insulin resistance, poor glycemic control, dyslipidemia, visceral adiposity, in addition to frailty and osteoporosis and anemia. Testosterone therapy has been shown to be an insulin sensitizer, and we first showed this in 2006, and it also increases muscle mass and reduces fat mass. Mortality is a problem with testosterone deficiency, as it's double compared with a man with diabetes and normal testosterone. However, if you replace the testosterone, survival is returned to normal. So we started this study to examine large numbers of men who have problems with testosterone deficiency, and a lot of data is collected. We collect data on symptom improvement, and there's a score system on the in the audit, but also you can actually insert the HbA1c symptom score, which is a more accurate way of assessing testosterone symptoms and improvement with treatment. So if we look at the figure 2, we will see that the data shows that the HbA1c at baseline is 8.6%, and after 3 months of testosterone therapy, in addition to normal care, it proves to 7.8%. 8.1%, and then at 12 months to 7.8%, and by 3 years it's down to 6.9%, which is achieving UK-PDS control levels, which improve and reduce the risk of complications of diabetes, both microvascular and macrovascular. From figure 3, we looked at the HbA1c symptom scores from baseline to 12 months. You'd expect symptoms to improve 3 to 6 months, but in diabetes it can take longer, up to 12 months. We have the score, lowest score in AMS is 17, highest is 85. At baseline, our mean AMS score was 40.83, which shows significant symptoms of testosterone deficiency. However, after 12 months, the score is down to 21, and these are normal in many patients, showing total resolution of the symptoms. So what we have seen is improvement in quality of life and symptom scores, as well as HbA1c. We need to do more analysis to find out whether or not certain patients respond better than others, and doing this audit will help us. If you wish to take part in the audit, the bottom right hand of the poster, there is a QR code which will take you straight to the ABCD Testosterone Diabetes website. The actual web address is also there as well. There is an audit officer who will contact you in regard to registration, and we'll be able to start you, and you'll be able to start. If you input your patients, then with that data, you will be able for you to access for your own audit of the patients you started on testosterone replacement. So I encourage you to put patients on, as we really need to get up to the thousands of patients to make good sense of our findings and promote. And we will need to see whether or not testosterone deficiency needs to be treated in these patients. Thank you very much.